Perfect. All right, so welcome to another day of awesome education by CHLA. We're going to start off this morning talking about our epilepsy monitoring unit. And so I'm Andrea. I'm one of the nurse practitioners on the epilepsy team.
And I'm Tanya. I'm also one of the nurse practitioners on the epilepsy team.
So we will go ahead and dive right in. This is just a picture of one of our standard rooms up on our EMU. As you can see, it's a private room, so no shared rooms. You can see the camera installed on the upper right-hand corner on the wall. And I don't know if you can kind of see behind the TV on the left-hand side of the wall. There is that box, and that's where the recording machinery is kind of kept safe and organized in one area. And the camera the camera records all around the room. And so the patient can walk around anywhere in the room and still be recorded. And it's obviously just not recorded in the restroom. So the types of admissions that we have in our epilepsy monitoring unit vary by length and by purpose. So the shortest study is an overnight 24-hour study. We do 48, we do 3 days, 5 days, 7 days, and 12 days. So the purpose of the studies could vary. Most of the time it's to capture and characterize spells. If the patient's reporting some funny spells and we just don't know if they're seizures or not, or they're happening every day, we're like, okay, come in for a study and we can try to capture them and see what they are. Sometimes seizure quantification, just maybe the parents reporting a lot of seizures at home but the kid seems to be fine in clinic and we don't see any seizures in clinic, so we just want to bring them in to just get an accurate seizure count. And then sometimes it's just to evaluate background, perhaps their routine and their overnight, perhaps their routine EEG was normal and parents continue to report daily spells and we just don't know what's going on. So we're like, okay, well, let's see an overnight shows anything. Or maybe it's already a chronic epilepsy patient and we're just evaluating their background to see if their background has changed to better provide treatment. We have pre-surgical evaluations, so phase 1s and phase 2s. So phase 1 is kind of our initial pre-surgical evaluation. So the goal of a phase 1 will be to capture seizures and to try to localize where the seizure onset is so that we can have more information on whether this patient is a surgical candidate or not. So pre-surgical evaluations for phase 1s are a minimum of 5 days, and then they can be 7 days and they can be 12 days. And the length of the study depends on the patient, on how often the child is seizing and maybe what medications they're on and how fast we think they'll seize with us reducing their medications, or sometimes we don't even need to reduce them. Phase 2 is intracranial monitoring. So these are patients that come in with, and they get depth electrodes placed or grids. So these patients are managed mostly by neurosurgery and hospitalist team. Our epilepsy team, we basically manage the epilepsy meds at that point. And so this would be if your child was scheduled for a surgery to place the leads and then had to stay for long-term monitoring. And then typically they would get a surgery at the end of their stay or scheduled at some point later on by the end of their stay.
Okay, so pre-admission. Typically, the APP, meaning the nurse practitioner or the physician assistant or the doctor that sees you in clinic will discuss with you and see if it's necessary for an EEG and to determine how long the study should be. Like Andrea said, it could be anywhere from 24 hours, 48 hours, 3 days, 5 days, or 7 days, and up to 12 days. So typically we'll place an order during clinic. And then the orders get sent to our PSR, Cecilia Pinto, who then processes the request, gets an approval through insurance, and then coordinates the admission date with the family. So typically she'll call families and discuss the best date for you guys to come into our epilepsy monitoring unit, which suits your life best. And then she'll typically email out a detailed instructions, which we'll go over on the next slide. Since COVID, we are required to test all patients that come into our epilepsy monitoring unit. We do have a convenient testing center here at the Rodney Testing Garage. We require that that all patients get tested within 72 hours of admission. And then parents no longer have to get tested through or cannot get tested through our garage anymore, but we do require they either show proof of vaccination or a negative test within 72 hours of admission.
So this slide shows an example of the email that Ceci will send out to the parent after she's talked on the phone with them and confirmed, like, okay, this date works for you. I'm going to be sending you a follow-up email with more detailed information. And so this is kind of what it looks like. I know it's a little bit hard to read, but we just wanted to show the example. So this is a confirmation email, like I said, after already speaking on the phone to confirm the date of the EMU stay. It goes over the COVID testing again. It gives the address for the Rodney Testing Center and the date and the time that the child is expected to come for COVID testing. It lists the admission date and time, which is also important because we want all of our patients to be on time. And it lists just some things that the parents can help prepare the child for the study. So things like making sure that the child has dry hair, doesn't come with wet, like freshly shampooed hair that's still wet or something. A reminder to bring button up or zip up clothes, because once they have the leads on, it's really hard for the child to change their clothes. If they're wearing like a regular t-shirt, like a pullover. So a button down or a zip up would be more easy to change. So a lot of our kids just come in, bring pajamas, and they just kind of stay in pajamas for the length of their study. And a reminder to continue their daily routine and daily meds. Typically our admission times are in the morning, usually around 10. On Mondays, sometimes they're earlier, around 8. So they're usually no later than 12. So most of our patients are on epilepsy seizure meds. And so it is important for the child to take their morning medication the morning of the test before they come in, or even as they're coming in sometimes. A reminder to bring any specific supplies that are needed. So sometimes if the kid is on specific G-tube feeds or if they're on CPAP at night, we ask that the parents bring that. And I know it's a little bit of a hassle, but it's because we just want to make sure that we have everything that we need here. And sometimes the hospital runs out of formula, or they don't have the correct CPAP machine with the settings that match. And so that's why those are important. And we just ask that if any patient or family member begins to have ill symptoms, that you reschedule your study, because we just want to keep everybody healthy in our EMU. And so we just ask that patients and families who have sick symptoms don't come.
Okay. So the day of your admission, you will typically park in our valet parking lot unless you're able to get dropped off, which sometimes can be a mess. And we understand that sometimes you guys have to go back to your car to figure out where valets put it and get things out of the car. But once you've figured out your parking, then you will come into the hospital and check in with admitting. And they will guide you guys up to our unit. The epilepsy monitoring unit is located on Dookie 5. And from there, you will meet your nurses and the EEG techs. Once you get settled into the room and the nurses take your vitals and your weight, then the techs will start placing the electrodes. That takes some time for them to get the correct placement. Then they'll wrap your head with the the white mesh stuff so that kids don't pull at it. And then from there, usually one of us, so either myself, Tanya, or Andrea, you'll probably see one of us in the EMU, or on Fridays, Julia will be there as well, who will come and introduce ourselves and get a little bit of a history and then kind of explain what to expect for your stay. And then for those that stay longer than an overnight, we'll typically meet the epilepsy doctor. And for every day that you're there, we kind of come up with a plan, depending on if we decide to continue your medications, or if we want to lower your medications, sleep deprive you, which we'll go over in more detail in a little bit, and things like that.
So during the stay, we just remind patients and families that they're being recorded at all times in the room. That's like the purpose of the study. And so this includes voice and video, and then obviously the EEG recording of the brain waves of the child. So like Tanya mentioned, some of the activations that we do in our EMU is a very safe and controlled environment. So, and our techs are experts at doing activations. The purpose of activations is to see if it will trigger any seizures. And our EMU is an interesting place because it's probably the only place in the world where we actually want kids to have seizures. So yes, we're performing activations to hopefully trigger seizures, because that's the purpose of our study. So the different types of activations that we have are photic stimulation, so flashing lights, hyperventilation, so asking them to do a breathing exercise for about 3 minutes. So typically this one, the kid has to be cooperative and kind of at a developmental age where they're able to understand that they need to be taking deep breaths and blowing out for 3 minutes straight. And 3 minutes is actually quite a long time to be doing this. And for the younger kids, we have a little pinwheel, which we'll show you later, that we kind of make it a fun game and for them to do. Sleep deprivation. So as you probably know, poor sleep is a very common seizure trigger. So sometimes for our longer stays, we will sleep deprive some patients if that's a trigger for them. And even sometimes if it's not a trigger, we'll just try it, because oftentimes it can help us bring out seizures. So typically for our teenagers, we cut their sleep down. We let them sleep 4 hours. And we let them have maybe a short nap the next day. And then for some teenagers who maybe their regular amount of sleep is 4 hours, then maybe we say, okay, can you stay up all night? And then for younger kids, maybe school age children, we kind of just work with what their schedule is. We'll typically ask, okay, what is their regular sleep pattern like at home? How many hours do they typically get at home? And maybe we just cut it by a few hours. And we have an exercise bike. It's not a Peloton, but it's a little old school bike pedal, which can kind of help bring the heart rate up. And then sometimes that will also trigger seizures because, our room is, a lot of kids come into our EMU and they're very relaxed. They just kind of sit in the bed, watch TV, order food, and there's not much activity going on. So the exercise bike can provide that. And then anything that the family can think of for specific triggers for that patient. So for example, there was a patient that was in our EMU and we were waiting for him to have a seizure, and it was like the 4th day and we were on the last day and still no seizures. And so the mom said, every time he looks out the window at the screen, he has a seizure. And I promise you, if I bring something like that, then he'll have a seizure. And so we said, okay, if you can bring that screen, that window pane, I don't even know how to explain it, but the one that keeps the bugs out, sure. And then so she actually brought it to the EMU. We put it, set it by the window, and lo and behold, the child had a seizure. So that was really interesting. So, obviously we have to work with what we have in the environment. And so that worked out. And what else can I think? Another example is a lot of parents say, oh, a loud noise or something something really loud will startle and trigger a seizure in my child. And so we'll say, okay, and so when we get desperate, we'll just go in there and we'll start maybe dropping a book, or maybe we'll slam the door really loudly on purpose to see if that would trigger a seizure. So we kind of work with the patient too.
Other examples too are like if patients say that like temperature triggers their seizures. So there's a thermostat in the room, so you can either turn it really hot or cold. Other triggers are like stressful situations like school or homework. So we ask like if you have homework to bring your homework with you so that we can stress you out. So these are the examples. The one on the left is the strobe light to induce like a photic stimulation. So it's placed in front of your face and it flashes kind of like a strobe light. The center is the pinwheel that Andrea was talking about that you'll blow to kind of make a game out of like hyperventilation. And then this is like it's as close as we can find to an example of the bike pedals that we have on the unit. Okay, so another thing that we do while you are in our EMU is testing. This is probably one of the most important aspects other than actually having a seizure that our amazing EEG techs do once the child has a seizure. So these are kind of guides for them depending on their age level. So there's an infant, there's toddler, young child, and adolescent. So for an infant that comes into our epilepsy monitoring unit who has a seizure, usually it depends on if it's a generalized seizure or if it's a focal seizure. So regardless of the type of seizure, the EEG techs will communicate into the room through the intercom. So you'll often hear them intercom in and ask if everything is okay, if they see a change on the EEG before something were to happen. And then if the child goes into a generalized convulsion where they do lose consciousness, then typically their priority is to come in and safety is their priority. So they'll turn the patient on their side and make sure that they're safe from falling out of the bed and everything. If the seizure is more focal, where they're not necessarily, they haven't necessarily lost consciousness, but they note like posturing of the patient. So they'll usually communicate through the intercom to other EEG techs in our communication center. They'll note posturing, or repetitive movements in their face and their limbs and their eyes. So they're communicating back and forth. Because an infant can't communicate back with you, there isn't as much testing that goes on, unlike for a toddler or a young child.
Yeah, so for a toddler or a young child having a seizure, so, some of the things are the same, like, the techs are assessing, okay, what is the level of consciousness of the child? And then so with a toddler or young child who can maybe be more verbal or follow commands, the tech would maybe ask them to, they would maybe pick up their toy and say, can you grab this? Or simple questions like, where's mom or where's dad? Can you point to mom? Can you point to dad? And they would test them and ask them, maybe, can you show me how old you are with your fingers? And so these are things that they're testing the patient where they don't have to verbally respond, but if they can if they can show with their hands, then that shows that they are hearing and understanding the information and following the commands appropriately. They will also note any repetitive limb, eye, or facial movements or any posturing, and the tech will be at the bedside and communicating that through the camera so that the tech in the communication center is making note of that and they're typing all these notes down. The techs may also remind the parents to just not block the camera, because oftentimes when the child's having a seizure, obviously it becomes a little bit of a stressful situation. It can be. And then so it's natural instinct to just run towards the patient in the bed. So just don't be offended or alarmed when the tech just tells you, oh, can you just move to the side and not block the camera? Because that's really important. We need to be able to see what the patient is doing. And crying usually indicates the end of a seizure. And so the nurse will be at the bedside and the tech will be at the bedside. And at that point, like, we're all just trying to reassure the patient and to let them know that they're okay, they're safe, and it's going to be okay.
And then for an older child or adolescent, again, it's very similar to what we would do for a toddler, except for we now can better communicate with an older child and adolescent. So we'll not only ask them to like point to their mom or to the window, but we'll ask them certain questions. We'll ask them to count to 10. We'll ask them to count we'll ask them what color a certain thing is. We'll ask them to look at an object and try to remember what the object is. And then later when they're no longer in the seizure, ask them if they remember what the object is. So there's a series of questions that the technicians will come and ask the patients at bedside. A lot of the times our nurses also are trained and know how to ask these questions if they're the first ones in the room. And then again, like Andrea had said, please try not to block the camera because this is our best way of seeing what these seizures look like.
All right, medications. So depending on the type of study, we will either give you instructions to wean medication perhaps before the child comes to the EMU, or sometimes we wean it after the child gets here, and sometimes we don't wean at all. So it varies. And so we would say that if you didn't get any instructions, if you didn't get a phone call before your study to give you specific instructions to wean your medication, then no, you're not weaning. You do not need to wean your medication for the study. And we only make adjustments to medications, like wean medications and taper them, for admissions 5 days or longer. So our overnight studies, our 2-day studies, our 3-day studies, they all stay on their meds. And we try to make that very clear, but you know, sometimes it gets confusing. So, and whether or not we wean for the 5 days or longer before the study or the day of the study, it's all case by case. And that's why we'll typically call the family the day before to kind of ask how many seizures are they having? What is their frequency right now? What meds are they on? Are these meds going to take a long time to for us to kind of flush out of their system, or is it something that we can give IV really quick? I think there's a few questions in the chat, but we will well, if it's okay with everyone, we'll answer these at the end. Thank you so much for your questions. So rescue medications that we have available on our EMU floor in our Pyxis, so readily available, are Diastat and a few other IV medications. So in general, everybody gets Diastat ordered for safety. And we usually instruct our nursing team to administer the Diastat if somebody is having a convulsive seizure longer than 5 minutes, or a cluster. That's kind of patient specific, but in general, it's like if they're having more than 3 seizures in an hour, or maybe more than 3 seizures just in the nurse's shift. If we are weaning medications, so for patients staying 5 days or longer, then they will need an IV, and that's for safety. And then once they have the IV access, then we are able to give IV anti-seizure medications to abort their seizure faster. And I think everybody would prefer IV medication before Diastat. So did we go over the 10%? Okay, so some of the IV medications that we have available in our EMU. So first line is Ativan. And then we have phosphenytoin, and we have other ones such as IV Keppra, Vimpat, and there's one more, I think.
But those are depending on if you're on those medications.
Yeah, so like we can't remember the third one right now, sorry. But there are a few IV anti-seizure meds available, but for example, we would only typically give you IV Keppra in an emergency situation if like that patient was taking Keppra and we wean them off of it. So not all anti-seizure medications are available IV. So most of the time we'll just do Ativan, phospheny, and then our last line is Diastat. And then nowadays, you know, a lot of our patients have Valtoco or Nasolam, the nasal sprays, which are great. We love them, but unfortunately, we don't have them available inpatient at our hospital yet. So if this is something that works for your child or our patient, then we ask that you bring that nasal spray with you to the hospital, and then we can have it available to use. But otherwise, if you don't bring it, then there's pretty much no way for us to get the nasal spray. And our only options are IV medications and rectal Diastat.
I think the two biggest takeaways from this slide is safety. We want you guys to have seizures in our epilepsy monitoring unit, but it's in a controlled, safe environment. So all these medications are made available in case of prolonged or cluster seizures.
And typically, because in our EMU, we only want to see the beginning of the seizure. So that's our goal. Our goal is not to see the whole convulsive event if that's how it progresses. So that's why we have these medications available on the floor so that they're easily accessible. The nurses can grab it quickly and we can administer it quickly if needed to stop the seizure before it kind of goes into a full generalized tonic-clonic seizure.
And just the other important point is that if we have not called you, like Andrea said, to give you a clear instruction on how to come down on your medication, if you have a study longer than 5 days, then make sure you take the medication at the same time you do every day in the morning. So we actually have a playroom that is safe for our patients that we do not wean medications for. So those that are any length of study that medications are not altered. There is, and I will show you a picture of it. There is a camera, if you can see in the back center ceiling. There is a camera so that we can, if a patient were to have a seizure in the playroom, that we could still record it. And before they walk over to the playroom, they're actually attached to a portable monitor so that we're constantly looking at their brain waves. And then once they get into the playroom, we're able to see them through the camera. So these are made available, again, for patients who are not off their medication, and this is mainly because of safety reasons. We need to be able to access your IV if we needed to as quickly as possible, and that's the most safe to be done in your room. It's typically open between 3 and 4 p.m. Monday through Friday, and 3 and 4 p.m. is blocked off for just our epilepsy monitoring unit patients. So that's pretty cool.
Okay, some frequently asked questions that we get. Will I see my primary neurologist during my stay? So oftentimes, yeah, we get this question a lot because, you know, we have so many different doctors in the neurology department, and any of them can order an EEG for whatever reason. And so the answer to this, unfortunately, is no, unless your primary neurologist is an epileptologist who happens to be rotating on EMU that week. So we have 4 amazing epileptologists in our program, and they all take turns being the attending on our EMU. So if by chance your child's study is scheduled on a week that your doctor also happens to be on EMU, then yes, you will see them. But otherwise, no, because we're just in a separate kind of area of the hospital, and it's just not part of their routine or schedule to stop by. But we are in very close communication with them, and we will update them on what's going on, and they'll obviously get a final report of the EEG, and we email them all the time if there's things that we're not sure we need to discuss or update.
And then just to clarify, typically you'll see, if you happen to be on at the same time your epileptologist is rotating through the EMU, you typically see them if your study is longer than 24 hours.
Yes, correct. can we complete other studies while we're admitted? So a lot of times our patients have, they're like, oh, we have a brain MRI, or the doctor mentioned we need an MRI, or I don't know. That's probably the most common one. Yeah, and so unfortunately, we cannot think of our epilepsy monitoring unit as a specific place that is only for EEG for EEG studies. And the point of the child coming to our EMU is to capture seizures or to record brain waves, and that's pretty much the only thing that we're allowed to do there. Because even though that's an inpatient admission, we're not on the Anderson main hospital side where it's easy for other departments to coordinate things. And so we're kind of, I don't want to say secluded, but we're just in a different and special area of the hospital where certain things just can't really be done. And so this kind of leads to the next question where can we have a consult from a different specialty? So, oh, my child has a G-tube and I'm having problems with it. Can GI come and take a look? And unfortunately, again, the answer is no, because we're in a separate area of the hospital, and our unit is only for EEGs, and so they just we just can't accommodate any consults from different specialties, unfortunately. Will I get my results before I leave? So most likely not, but like Tanya said, if you're staying longer than a day, we come in and we round every day and we give you an update day by day on, okay, what did we see last night? What have we captured so far? So we kind of give you preliminary results if they're available, but for overnight, if you're just staying one night, then most likely not, because our doctors need sleep too. They don't stay up all night reading the brain waves. And so they typically get up early though the next day and they'll review it in the morning. But our discharges typically leave by 10. And so sometimes there's not enough time to review the whole study and to give you that final report before you leave. But typically the final report is available, I would say, within 2 weeks of your discharge. And so we always tell families, if you don't hear from your primary neurologist with the results in 2 weeks, you can feel free to call and get those results. Will we make any medication changes during the admission? So this kind of goes back to what we already discussed. We only make medication changes for 5-day studies or longer. And to just please, and it kind of leads into the next question, that do not stop your child's medications before the EEG. We get this a lot. There are some exceptions, but we will communicate that with you. So if you didn't hear anything, if Ceci told you, yes, take your medication, come for your COVID testing, stay in your remission, then please continue everything as routine. Another common question we get is about meals and refrigerators. So one parent is required to stay with the patient at all times, and that's for the child's safety, and also because the parent or the family member knows the child's seizures the best and can kind of maybe like notice things that we may not. So obviously if the parent's staying here, then they will need a place to sleep, they will need food to eat. So I saw one of the questions. Yes, there is a bed in the room for the parent to sleep in. It's like a pull-out bed, not the best, but I think it's okay. It's actually wider, than what I've seen. It's pretty, so it looks okay. And the parents are able to order food just like the patient orders food service for the food to be delivered to the room. The parent's meal just costs $5. That can be paid with, I think, cash or card. And then there's a cafeteria that's open, and then a lot of our parents, they order delivery food and they just have to pop downstairs to grab it. Sometimes patients are on specific diets, or they are really picky and they only eat specific food, so parents want to bring in their own food. There is a refrigerator, not in the patient room, but on the floor, on the unit. And so parents are welcome to bring their own home cooked food if they like, and they can store it in the fridge. We just ask that you don't bring a lot. We just ask that you be mindful for space wise, because the fridge is shared with the whole unit. And so yeah, we just ask that parents be mindful about how much food they're bringing, how much space it takes up. And then I think there's some policies, the nurses would know better, but about like the food going in and out of the room a lot, just for infection prevention. Just like, for example, I think once something is heated up and brought to the room, I don't think that it can be like replaced back in the fridge for storage. I think it just has to be like proportioned out, and we just have to be mindful of that.
And then also for those that have medications that need to be refrigerated, we asked you to bring all of your medications with you so that we can verify everything. But we do have a refrigerator in the nurse's medication room that they can store the medication for you in a refrigerator.
And the reason we ask parents to bring, oh no, it's okay, you can go to the next slide because it has the medications on there. But we say, don't forget to bring your medications. That's actually our epilepsy team dressed up as different seizure medications for Halloween. So we thought that was funny. But the reason we ask parents to bring meds is not because we don't have them here at the hospital. Although sometimes there are meds that we don't have. So that's one reason we ask parents to bring the meds. And also because we make so many changes to seizure medications all the time by phone, by email. And so we just want to make sure we're on the same page, and that at least we can check the bottle to say, okay, this is what is prescribed. And is this what you're taking? Is this not what you're taking? So that we can be very clear. And this is also important if your child is on specific brand medication, because hospital typically only has generic. So if you know that your child is on a specific brand or takes a specific manufacturer and you want to stick to it, then that's even more important for you to bring your medication with you, because it's not guaranteed that we'll have the exact same one.
We also asked to bring the other medications that your child is on, not just your seizure medications, because when you do come into our epilepsy monitoring unit, we do have pharmacy dispense all of the medication. So we do want to clarify the medication doses of all of your medications, not just your seizure meds. And then these are just other little reminders to bring something to wear that's buttoned down or zipper, like Andrea was talking about. Any type of specific formula. I think we may actually have Peptamen Junior here.
I think we have that, yeah. We have a
Pediasure,
few common ones,
but not all of them. So if you want to be sure to just bring your own.
And you can always call us and ask. We always get questions like, oh, well, I'm staying for 12 days. Am I expected to bring like 12 days of my my child's feed? And so, sometimes if you can tell us in advance what it is, we can check to make sure it's in stock. And like Tanya said, we generally have everything. But there's always someone on a special formula or like mixed with something. And if we don't have that exact feed, then we'll have our nutrition department or dietitian come and kind of see what we can make work. Yeah.
And also, if you're actually on the ketogenic diet and you use formula, we can have our ketogenic dietitians here make that formula for you while you're here, so you don't have to bring it with you and refrigerate it here. So those are typically done through our dietitians here. Any other thing about formula?
No, I think that's it about formula.
Other things that aren't pictured here, like G-tube supplies. We have some, but it's not compatible with all types of G-tubes.
Yeah, so bring an extra one just in case.
And then if you're on the CPAP or BiPAP.
Yeah.
And then questions. I know that there was quite a few. Oops, I don't have that. Let me go through them.
All right, we'll go through them in order.
Okay.
All right. Is there
a way to mimic a car ride to trigger a seizure? That's a really good question. We're open to suggestions, but unfortunately, we do have to keep the patient in the room. That's a very good question.
And there's not, the room is spacious, but not that spacious to I don't think to be able to do that. I guess one way that I could think of is if there was a YouTube video online of a scene, like of a window, of someone, of simulation of someone in a car and driving by, but we've
never experienced that. Yeah,
so
but
that's
we can get creative.
Yeah. We can maybe think of ways.
Someone else was asking if besides the parent, is there a staff member in the room? So the parent has to stay in the room the entire time with the patient or their child. There isn't a staff member in the room the entire time, but there is always a nurse available, and then techs that are available as well. Especially when there's a seizure, they'll come into the room. There'll actually be multiple staff members that come into the room if your child is having a seizure. But if the parent needs to take, a 15-minute break or go downstairs to grab something to eat in the cafeteria, we will typically have like a nursing assistant come and sit in the room while you make that quick errand.
Does nursing staff rely on EEG tech to inform them that the patient is having a seizure? Pretty much. So yes and no, because the techs, I don't think, are allowed to say whether something is a seizure or not. So you'll hear them say their patient is having an event, I think, for the most part, unless it's very, very obvious. But sometimes the nursing staff will see something happening themselves and then ask the tech kind of what's going on. But I don't think the tech is actually allowed to say if it's a seizure or not, but they're allowed to say that the patient's having an event.
That reminds me, we didn't actually touch on the fact that you do have a push button in the room.
Right.
So there's not the call light that you'll see like in the bed, but there's a separate red button that you press if family thinks that they're having a seizure, or if they're having a seizure, or if the patient or the child feels like they're having a seizure, they can press the button as well. And the button does alert the entire unit. So it will alert the nurses, and it will alert the EEG techs, and it will then obviously trigger the nurses to come in and make sure you guys are okay.
Yeah. But the nursing staff does work very closely with the EEG tech and rely heavily on what their findings are to kind of know what's going on. And then usually the EEG tech will be watching the brain waves in the control room, and then they'll say, okay, it looks like the event's stopping, or the event's over, and then maybe the child is still doing stuff. So that's helpful. So yes, the nurses rely a lot on the EEG techs to kind of for communication.
I think we already touched on this. Is there a bed for the parent in the room? Yes, there is. It's like a couch that pulls out into a bed, and then the nursing staff will provide family with sheets and pillows. They're not necessarily the most comfortable. So if you want to bring sheets, blankets, pillows from home, we suggest you to do that. Then another question: how does the camera follow the patient? It's automatic. That there's always in the control room, there are multiple EEG techs that are looking at not only video and sound of each child in each room, but also their EEG, so their brain waves. So as they're watching the video, and there's always someone who's looking at the video 24 hours of the day, every day,
the EEG tech will manipulate the camera to continue following the patient. So you'll see when the child moves, and they'll use their mouse and they'll move the camera, and then the patients in the room will hear a zzz, kind of noise.
You'll notice
the camera is moving. How many kids are allowed in the playroom at the same time? Yeah, that's a good question. So I believe it's 3.
I think it's 3 right now.
Yeah, for COVID.
Yeah.
So it typically works out because, like Tanya said, that time in the afternoon from 3 to 4 is blocked off specifically for our epilepsy patients. And we typically don't have more than 3 that can go at the same time. So, and I always reassure the parents, and the child too, it's going to be another kid with the leads on. So it kind of just makes them more comfortable, so they don't feel like they're the only ones in there in the playroom with this thing on their head. So everyone there is going to have the leads on their head, just like you, and the kids have been tested negative. So it's a safe place, and it's an opportunity for them to get out of their room once during the day. So that's really nice for them.
Another great question. Does CHLA offer the option for ambulatory EEGs to be completed at home? The answer is yes. So for those that don't know what an ambulatory EEG is, it is an EEG that we place here at CHLA that is portable, that you will take home and then be in your home environment, and then you bring it back to CHLA to get all the electrodes removed from your head, and then it's read by one of our epileptologists, and then we touch base with you again at home. So this is an option. We don't always recommend it for every patient. It depends on if we want to be able to record you from our camera a little bit better, since the camera that comes with this isn't as good, I guess.
Yeah, it's not as high quality of a study, but it is an option, and it's typically an option for our patients who are developmentally appropriate, who are not autistic, who are not going to be pulling off the leads at home or kind of at risk for ruining the equipment. And the longest ambulatory EEG study we can do is 72 hours, 3 days. So that's the longest. And we will not wean meds for this. This is something for if you just come and get the leads on, take the machine home, get monitored at home, just monitoring only, and then come back and get the leads taken off.
And yes, the camera will be provided for the ambulatory EEG. However, like Andrea said, the quality isn't as great.
But it can be helpful.
Yes. And we do it all the time.
We do it all the time. And sometimes if, patients are more comfortable at home and they can do their own thing. And so sometimes it can be really helpful.
Another good question.
Our own camera.
Can we provide our own camera that is better quality? So I don't think that our epileptologist can see your recording at the same time as the EEG. It's something that you could probably bring the recording to your clinic visit and have your doctor look at it. But to compare it with the EEG at the same time, we wouldn't necessarily.
Yeah, it's probably not compatible with the equipment that we have for the EEG, but you could do it separately. So that's a good question. Thank you, everybody.
Yeah, thank you
for your great questions.
We look forward to meeting you guys in our epilepsy monitoring unit.
If you ever come, you'll definitely meet one of us. So we hope to see you there.
Okay.
And I hope you guys have a good rest of your day. And I guess we'll take I don't even know what time it is, 9:50. Okay, so we have 10 minutes for a short break before our next presenter. So we'll see you in 10.